On behalf of the Patient Safety Authority, I would like to welcome you to this webinar titled Non-Traditional Learning Needs Assessments to Guide Staff Education. My name is Molly Quisenberry, and I will be your moderator for this program. A copy of today's slides is available using the link provided in the chat box. The chat box can be found by clicking on the chat button in the lower right corner of your screen, and then you will see the chat bubble. The webinar will be available in a few weeks on the Patient Safety Authority's YouTube channel. We welcome any comments or questions. All materials are provided for your educational use. Now I'd like to introduce our speaker for the webinar. Judy Bowman is a clinical staff nurse with 39 years of experience in para-anesthesia nursing. She currently works at the Reading Hospital SurgiCenter at Spring Ridge as a quality analyst educator, where she has achieved the distinction of an RN Level 5. Additionally, she is responsible for quality initiatives, education, infection prevention, risk management, patient safety, evidence-based practice, credentialing, privileging, and regulatory preparation. None of the planners for this educational activity have relevant financial relationships to disclose with ineligible companies whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. Judy, I will now turn the program over to you.
Thank you, Molly, and thank you everybody for giving me this opportunity to share with you how we approach learning needs at our center. So full disclosure, I am by no means an expert as an educator. So I hope I can still give you some tips or tricks that you might be able to use, that you might be able to incorporate and find helpful. So hopefully at the end of this presentation, you'll be able to discuss ways to conduct a non-traditional learning needs assessment to meet the needs, the educational needs of the unit. Hopefully discover how knowledge gaps gathered from that learning needs assessment can be utilized for staff projects, and describe how the learning needs of the staff can facilitate the bridge to conducting EBP projects. So at an ambulatory surgery center, you wear many hats. As Molly was telling you, there's a lot of things that I'm involved in, and education is just a small snippet of what I do. My biggest focus always has to be on infection control, which according to regulations, I'm supposed to be spending 15 hours a week conducting. So I try to squeeze all these other things in my spare time, as you might say. All right, so the Reading Hospital SurgiCenter is a freestanding ambulatory surgery center. We're part of Tower Health, which is a 3-hospital system based in southeastern Pennsylvania. Reading Hospital is our flagship hospital, and it has roughly about 700 beds. It was magnet designated in 2016, redesignated in 2021, and we're in our window for redesignation again. So the surgery center is a multi-specialty outpatient surgery center. We perform about 6,000 cases a year. Being multi-specialty, we do orthopedics, GYN, general surgery, GI, plastics, dental, ear, nose, and throat, pain management, GYN urology, podiatry, and neuro. We have 8 OR rooms and 1 procedure room to accomplish all of this. And the other thing that's interesting about us is pediatric patients make up about 1/3 of our patient population. I'm happy to report that 100% of all of our eligible OR staff are certified in their specialty, and about 75% of all the peri-anesthesia staff are certified in their specialty. Numerous staff members have achieved their BSN, and we actually, in addition to leadership, have 2 staff nurses that have their masters. In 2024, I'm proud to say we were the Patient Safety Authority winner in the ambulatory category. Also this past year, we received the OR Excellence Award in Patient Safety and Quality. And in 2023 and 2024, Newsweek voted us one of the best ambulatory surgery centers in the United States. So very, very proud of our accomplishments and our staff. So why is a learning needs assessment important? So what I found is that a needs assessment is a systematic approach to examining what individuals or groups need to learn. A needs assessment is a continuous process, and hopefully the goal of your needs assessment will be the transfer of knowledge to the staff. One of the things I always need to consider, or you always need to consider, is Benner's novice to expert theory. Nursing, healthcare, there's always lifelong learning that's involved. The second thing, the primary purpose of a learning needs assessment is to assist with and enhance planning of educational activities. It allows you to prepare for changes that are occurring versus needing to react to them. And it provides information to educators to take action. The medical environment and the needs for new knowledge, like I said, is always changing, therefore creating an ongoing need for education and training. So the needs assessment can help lead to improved safety, quality, and patient outcomes by allowing educators to close the knowledge gap and skills training that the learner may have. It also allows you as an educator to allocate for needed resources. Also, one of the reasons for conducting a learning needs assessment is not just to document that education is needed, but also to examine what learning strategies will help the learner to acquire the skills and then therefore fulfill regulatory requirements. So preparing for a learning needs assessment. So in the past, prior to me taking this role, learning needs assessment was sent out, and as a staff member, I filled it out, and I really had no idea what happened to it afterwards. So really, I had nothing to build upon when I accepted this role. So I had minimal knowledge about how to conduct a learning needs assessment. So what I did is I went to the literature to see what steps I needed to take. Now, mind you, like I said, prior to me taking this role, we did not have a formal quote unquote educator in our unit. So as I said, I went to the literature to see what I needed to do. So when I went to our medical library and just did a search for learning needs assessment, resources, specialty, procedures, etc., I came up with 342,000 hits and thought, wow, I think I'm a little in over my head. So what I needed to do is kind of refine that as to what would work for me in an ambulatory facility. So taking a step back, I graduated with my master's back in 2013 and assumed the current role that I'm in 2020. And we all can remember what happened in 2020 when COVID happened. All my energy kind of needed to be focused in other areas. So a lot was taken away from education. I was more focused on infection control. I was more focused on now needing to come up with temporary privileges, emergency privileges for surgeons, because a lot of surgeries were being diverted away from the main campus and the sicker patients over to us at a freestanding surgery center. So learning needs and education kind of took a little bit of a back seat there for a while, unless it was a true emergency. So also what I discovered when needing to do a needs assessment is I kind of went back to the tools that I had from going back to school and getting my master's. And what I realized was developing a needs assessment was something few educators were taught how to do. So I did discover that a learning needs assessment could be conducted through formal and informal methods. Formal methods included audits, surveys. They were structured and planned training, educational opportunities, and the goal was to improve clinical practice and meet organizational goals. Surveys, questionnaires were frequently used by educators because of their simplicity, and it was something that we were familiar with. More informal methods included observations within the unit and review of incident reports. So that allowed you to see if there were any emerging trends. So the first thing I needed to do was to conduct a needs assessment to determine what clinical knowledge and skills the learners needed to acquire and how they could use those skills to improve practice. So I quickly found out that a needs assessment is a self-assessment of the learner. But then I also needed to think, who are my learners? The needs of the OR staff were going to be way different than the needs of my peri-anesthesia staff. And then also I needed to decide the need for education. Was it an actual need or was it a desire from the staff? This also helped me to prioritize the needs. And then I needed to think, what were the resources that were needed? Was I going to need to create a PowerPoint? Was this going to involve hands-on training, simulation? Did I need to bring in equipment reps? The next thing was to develop a plan to meet the needs of the staff and then document and track the status of what was going on. Was the knowledge and skills being retained? Was it being maintained? And then the next thing I found out that I needed to do was kind of come up with a 12-year calendar to plan the activities throughout the year. Okay, I learned that I needed to consider, there were 4 considerations for a needs assessment. I needed to think about the present state of staff learning needs. So this was determined by the learners themselves. I needed to know if the learner I said was expressing a wish or if they truly had a learning need. A specific need during the course of work could be identified that was not captured in the needs assessment. So sometimes staff would come to me and say, hey, this is something that I have a question about. It's something that I think we need to learn. Also, staff observations can help identify a need. And then the need also may not have been identified as a personal need. This is something that I myself as an educator could have identified by going around and seeing what workflow looked like. Did staff look like they were struggling with something? The challenge always becomes deciding which education needs to become a priority. So we work in ever-changing conditions and therefore needs assessments need to be continual processes. Learning needs that generate qualitative data are easy to measure. That I found out right away. Whereas qualitative findings, such as how do you feel? Are you developing critical thinking skills? These were difficult to teach and also difficult to manage and measure. So you always need to think about what is going to be your process measure and what is going to be your outcome measure. Your process measures can always be things like chart audits. Are we doing what we need to do? Outcome measures are things that you look at, like, are we decreasing length of stay? Are we decreasing pain levels, nausea and vomiting, things like that? And then the other thing too is you always want to involve as many people as possible in identifying what the learning needs are. By involving other people, you prevent bias from occurring. So gather information from leadership, advanced practice nurses if you have them, and staff leaders who also know what the needs of the unit are. Okay, the next thing I found I needed to do was prepare for conducting the learning needs assessment. So again, elicit help from other staff members. Use those nurse managers, clinical specialists, staff, and physicians. Consider the time it was going to take to distribute and develop and distribute the learning needs assessment. Think about when you're creating the needs assessment, how will the topics be gathered? Do you want the education and training to be restricted based on available resources, or should staff be allowed to request any topic? Are you going to ask questions on a Likert scale, like how confident are you with your skills or your knowledge to do your job? How confident are you in your abilities to complete tasks? Indicators can include feedback from physicians, quality reports, and incident reports. Quality indicators always include patient outcomes or any changes that might be needed in relation to nursing sensitive indicators such as falls, hospital-acquired infections, pressure ulcers, and things like that. One of the other things you can use is patient satisfaction surveys. Results can be used to provide the educational needs for the staff. Are there any expressed concerns that were posted by patients that can be analyzed for potential weaknesses? Next thing is, how long do you want your survey to be? And how will the assessment be distributed? Are you going to email staff? Is it just going to be a piece of paper that you give to them? Is it something that's going to be posted on a board? Hey, learning needs assessment, write down what your examples are. And how long do you want the staff to be able to return that assessment? What is the right amount of time for them to consider what their needs are? You need to give them enough time to consider what their needs are, but you also don't want them to lose interest or actually lose the survey. So the next thing I needed to figure out is what were the components of a needs assessment? So I found out that really a needs assessment can be divided into three categories: organizational, task, and person analysis. So organizational analysis is the process of assessing the broader context, group, and organization in which the curriculum will be integrated. It makes sure that the curriculum aligns with the goals, needs, and strategies of the organization. And it helps to make sure that the curriculum aligns with what the needs of the learner is. Task analysis is the process of studying tasks needed to perform a job, the working conditions which the tasks are performed, and the knowledge, skills, attitudes required to perform that task. The results from the task analysis will inform the learning objectives of a curriculum by what the knowledge, skills, and attitudes are the learner's needs to acquire and perform that task. Person analysis. So it's the process of who needs the training and is the learner ready for the training. The goal of the person analysis is to ensure that the curriculum design meets the specific needs of the learner. So education is ongoing and you're constantly assessing the learning needs of the department, the unit, the staff, and anytime a new service is offered, new equipment arrives, new medications are ordered, are there emerging diseases and outbreaks, or is there a change to recommended practice standards? So the steps of conducting a needs assessment. First is identify what is the purpose. So the purpose of a needs assessment and the anticipated needs of the staff. What is the reason for the need? The needs assessment is the process of assessing the training and educational needs of the individual, group, or organization, and then aligning their needs with the curriculum. Clarification of what the problem is will help plan curriculum for the learner. Hopefully, the purpose will be to improve practice, identify gaps, again, identify who your learner is, and prioritize what those learners' needs are. You need to identify what is known, what is required, but not known by the learner. And then what are your characteristics of the learner and the practice environment? Technology has affected the way training and education is provided. So think about your learners. My staff that's 35 and younger understand technology so much better than my group that's age 50 or over. My group that's age 50 or over tend to like more traditional learning methods versus the younger generation. But the other thing too is consider that blended learning is becoming more the norm to meet what the learner's needs are. The next thing is selecting or creating a needs assessment tool that will allow an assessment to be conducted. So are you going to use a questionnaire? As I said earlier, is it going to be on paper? Are you going to email? Are you going to ask open-ended questions? Or are you going to allow the staff to request anything? And then after you get your results back, you need to analyze those results. Are there overwhelming trends that you can group together, or are you all over the place with your staff? And then you need to do an ongoing analysis. It's not just that you get that initial response. You need to continuously build upon that analysis that you've received. The needs should never stop once the education is planned and presented. You always need to continue to measure those learning outcomes. Were those objectives met? How do you know the objectives were met? Well, you can administer pre-post tests. You can distribute surveys. Go out into the unit and do some direct observation of staff. Can they provide return demonstration? You need to continuously measure the learner's ability to transfer that learning into the clinical setting. And then also get feedback from staff, get feedback from preceptors and mentors. And then the last thing is communicate findings. Let the staff know what your plans are, and then what the findings of the ongoing analysis is. Is staff retaining the knowledge, or do we need to do some sort of re-education of staff? Okay, identification of knowledge gaps. So by conducting a formal gap analysis, you can find where the gaps occur. And then a gap can occur when there's a difference between what the learner knows and what the learner needs to know. It is normal to have gaps when you have novice nurses or new staff members starting in a role. Also, you also need to think about when new equipment is brought onto the unit. This is something new. Everybody's going to be novice nurse in that particular instance. And when you think about Benner's novice to expert theory, you have staff out there that have a great life and work experience that can influence their responses to learning activities. But then you also can have the new graduate, and hopefully the two will create a relationship where they can build off each other, where the seasoned nurse can share her knowledge, his or her knowledge, with the new graduate, or the new nurse who has taken on, or even the seasoned nurse who has taken on a new role. You need to consider findings from research when doing a gap analysis. What do the experts, oh my gosh, what's the word I want to use? What do the experts recommend? You want to utilize a gap analysis to identify and assist learners when performance is different from expected competency. Making sure that those learners really know what is needed and have the tools to perform their roles. You want to use knowledge gaps that are identified when measuring performance outcome, when you're looking at quality improvement initiatives, or when you're doing examination of sentinel events. You want to know, was the staff adequately trained and prepared in order to do the task? And then you need to figure out if there's a need to know that a gap, you need to figure out the need to know if the gap is resolved around knowledge, practice, or skill. And then if the identified problem is an educational issue, the next step would be to include determining if the deficit is present for just one person or an entire group. Okay, findings from a needs assessment. Conducting a needs assessment prior to implementing a professional development opportunities may lead to more meaningful change in practice. So use that needs assessment to address genuine expressed needs of the learner rather than what is theorized as a need. You need to look to identify the learner's needs, what their topics of interest are, and are there barriers to them learning. Adults want to know why they need to learn something. Continued professional development through lifelong learning is necessary to assure that staff are up to date with needed knowledge and skills to perform their jobs. And then you need to communicate findings from the survey. You need to be flexible. This is, I think, one of the biggest things that I learned. Crisis management is well known to educators, and unfortunately, I think it happens far too often. A quick response is needed to meet the needs of the unit of the organization. How many times does new equipment show up on the unit that requires staff training? And as the educator, does it feel that you were the last person to know? The decision was made that something was needed. The order was placed, the vendors were here, the equipment arrives, and now you're finding out that staff need to learn how to use the piece of equipment in order to obtain competency. Also, announcement of newly mandated employee education or training. That can come through Joint Commission, or for us, a lot comes through ARN, looking to revising their standards, which will then require staff need to be re-educated in order to be survey ready. Curriculum development. So curriculum development based off of needs assessment helps develop learning objectives. It helps to develop the curriculum design and the method of delivery. The key is choosing the correct educational approach. Curriculum development also helps improve learning and transfer of learning to patient care. And the most important reason for learning or education is to create a change in the learner. After all, learning is a process of acquiring and using new knowledge. It happens during planned teaching learning sessions, but it also happens in unplanned events that occur with clinical practice. As I said, watching the seasoned nurse on the seasoned nurse on the unit, sharing tips and tricks with others. Teaching means to instruct or impart knowledge or skill. This can occur through mentors and preceptors. Training is a learning experience provided to employees in the work setting, and the purpose of training is knowledge and/or skill acquisition to meet the expectations of the role. The hope is that learners will be able to apply that information from learning sessions, thus creating a transfer of knowledge. And the goal is that the learner will be able to practice new skills and apply that new knowledge in the unit. To evaluate this, it can be done through demonstration and return demonstration, which is something that can be accomplished individually as groups. It can be done scheduled or it can be done on the fly. Competency. So clinical competency is needed to prevent mistakes. A single mistake in the OR for us can have serious consequences. Proper training is required to help prevent any complications or compromise patient safety. Serious events related to patient care can compromise the ambulatory surgery center's quality scores, which can in turn affect our accreditation recommendation and also affect reimbursement rates that we see. Standards also that are set forth by Joint Commission and CMS, we need to adhere to, again, to make sure that we can maintain accreditation and our reimbursement rates. The ambulatory surgery center arena, we report quality data to regulatory agencies, and if we do not meet and we do not report this quality data, we can risk a 2% payment reduction from CMS. So competency assessment is very important to us. So the next thing I did was I looked at the difference between competence, competency, and competency assessment. So competence is the ability to perform a task. Are your staff ready? Do they have the skills in order to do that? Competency, as I said, competence is, can they complete the task, and competencies is the ability to perform a task in the real working environment. It indicates that the employee has the necessary skills or performance in a given situation, and then competency focused on the actual work environment. The Joint Commission defines competency assessment as a review and the documentation of the individual's ability to achieve the expectations stated in their job description or performance standards. Competency assessment is an important component of orientation for all new employees or when someone changes roles within the organization. A learning need is a gap between what the learner knows or can perform compared to what is required on the job. And learning needs can be identified by interviewing staff, conducting brainstorming sessions, going out into the unit and observing staff, asking for surveys, looking at test results, and also monitoring your quality indicators. Learners need to be able to evaluate their own needs for training. The learners need to be able to evaluate their own needs for training and have confidence in have confidence in their ability to apply the skills. So now that I went to the literature and found all this information on how to conduct a needs assessment, I was ready to get started at Spring Ridge. So with all my information, I explained to the staff why a learning needs assessment was important. I distributed the learning needs assessment in an attempt to elicit responses from the staff. The first thing I did was I gave them a paper form to fill out. One was given to each employee. And then I followed up with an email reminder like, hey, I sent you that needs assessment. Please fill it out and please give it back to me. Didn't really get too much response from the staff. So I thought, okay, next thing I'm going to do is I'm going to put up some sign-up sheets and I'm going to post them around the unit. Like maybe as they're, throughout their day, they might think of something and this might jar ability to give me something here and now, just jot it down on the piece of paper. Still really didn't get anywhere. So the next thing I did was I sent out a survey monkey to each staff member. Like, okay, maybe you lost the piece of paper, maybe you ignored my email, maybe you didn't take note of the pieces of paper posted in the unit. So I sent out a survey monkey. I even tried to list some examples of what I thought would stir interest in others. And at the end, I found out it was really my own list. So talk about not implying bias in learning needs. Here you go. This is what I was doing. So after all this, I would maybe elicit 1 to 3 responses or stated needs. And when you think this is like 75 staff members that I'm talking about, the needs that I got back were usually submitted anonymously. So if there was a question about what the stated need was that I didn't quite understand, I wasn't really able to go back to the staff to clarify and get additional information. So this left me very disappointed, frustrated. I was confused because I thought I had an idea about what I was supposed to do and how to accomplish this for the staff. And I thought I was prepared to meet the educational needs of the unit. Well, obviously I wasn't with this approach. So I had to think and rethink about our process. I needed to think about how our unit functions and how I could use what we're doing already as necessary and combine it into a needs assessment for the unit. So what I did was, when traditional needs or methods of conducting needs assessment was unsuccessful, I got creative and started to think outside the box. I started to leverage the learning needs of the unit against the professional requirements of the staff. So here at our surgery center, because we're tied in with our main campus, we utilize a prep program, or a lot of you might know it as a clinical ladder. So it's an incentive for staff to create learning opportunities. And it's also an incentive for staff to go up the clinical ladder or go up the levels in the prep program. So the prep starts out at level 1, which is the new graduate novice nurse who hasn't really even passed her boards yet, is still kind of working as a nurse extern, things like that. Level 2, now the nurse has passed the boards and is ready to expand their abilities. Then there's a level 3. So a level 3 nurse is someone who fulfills the minimal requirements needed when you're looking at precepting, being members of shared governance councils, things like that. A level 3 nurse either has their bachelor's degree, is working towards their bachelor's degree, or certified in their specialty. Level 4 does everything that a level 3 does, but then also definitely has their bachelor's degree and is certified in their specialty. A level 5 nurse has their master's degrees certified in their specialty, but also does EBP, research projects, quality assurance projects, things like that. So each time you go up the clinical ladder, the needed level to maintain that continues to go up. We continue to up the ante. Prep projects are something that each person needs to do in this clinical ladder. It can be as simple as conducting an article review for a level 2, a level 3, or it can be as elaborate and complex as a QI project or an EBP project for a level 5. So I thought the prep program is something that all nurses are engaged in, and I thought it created an opportunity to leverage professional requirements with learning needs of the unit. And I thought, here's my aha moment. Here's my perfect match. So I started collecting learning opportunities throughout the year. When I would come across information in articles, webinars, listservs, new procedures, policy review, practice standards, or just having that moment of clinical inquiry when you walk into the unit and you think, okay, does the staff really understand why they're doing what they're doing? Or are they doing it because this is the way we were taught how to do it? Do they understand the reason, rationale behind it? And what I started doing was making notes, jotting down ideas, and printing out these articles. And what I did was I created a folder of what I called my finds for future use. So each year, our staff meet with our director of nursing and myself to discuss what these prep projects are going to be. Most staff members came to these meetings and they struggled with ideas to come up with a project. So I started using these opportunities of them struggling as a way to share what was inside my little magical folder with the staff. I looked at my staff members and I started to focus on topics that were relevant to their area of practice, whether it was OR related or peri-anesthesia related. I started to utilize their resource roles. So at an ambulatory surgery center, I'm not the only person who wears a lot of hats. Our staff members are resource roles. So one of our resource roles is pharmacy. We need to order all of our pharmacy supplies. We need to put away all of our medications and things like that. Electronic health record is a resource role for someone. Different specialties in the operating room each have a resource role, ENT, ortho. They become the resident experts when you're looking at those surgical procedures. So when I started thinking about topics of interest, I thought about their resource roles and thought, is this something that, first of all, they do have a basic and expanded knowledge about to begin with. It's relevant, obviously relevant to their area of practice, and I would imagine that they would have an interest in it. And anytime your staff members are presenting their projects to other staff members, new knowledge is gained. Prime example, we had one of our nurses who is a plastics resource nurse did a project on breast implants. Her presentation looked at breast implants and why people get them, different implants that are out there, how they're implanted. But the aha moment, I think, for most of our staff members came when she talked about explantation. I, for one, kind of thought they get implanted and you live happily ever after. I didn't realize that usually at some point in time they need to be explanted and new ones implanted. One of the other aha moments for most of our staff members is the risk for a secondary cancer from breast implants. That was something that was new knowledge gained by all of our staff members. So even though this fortunately was a podium presentation, but even if it's sharing a journal article, there's usually new knowledge that's imparted to our staff. Also, anytime you're adding new knowledge, it improves patient education, which ultimately improves patient satisfaction and hopefully decreases complications and hopefully leads to decreased emergency room visits of your patients. The other thing is by rethinking our process and using these open houses and sharing ideas, by going back and conducting chart audits, I was able to see if practice was meeting expectations and also how were we performing. Where we saw there was an anticipated need and we provided education, was it sticking? Were staff doing what we expected them to do? Hopefully, if this learning was relevant to their area of interest, it was something that stuck with them and it was something that they incorporated into their daily activities. And then also, when we were looking at our educational open houses, we were looking at updates to standard manuals. Anytime AORN updates their standards, looking at what those updates are and are we practicing up to what those standard requirements recommend. Also, evidence-based practice. When you're looking at conducting an EBP project, sometimes you're looking to conduct an EBP project and sometimes an EBP project just sneaks up upon you. Sometimes you walk into the unit and as you're looking around the unit, you have that moment of appreciative inquiry where you look at something that's being done and you think, again, as I said, Are we doing what we should be doing? Is there a better way of conducting that? Let's go to the research. Let's go to the literature and see if there is. Are we on point, or can we improve practice? And then after you do look at the literature, you appraise what that literature tells you. Is it a clinical trial? Is it a randomized control trial? Is it expert analysis? What are you looking at? Can you come up with enough information to warrant a practice change? And then always looking to evaluate your outcomes. So how do you benefit? Well, what we did by coming up with this new method is we improved performance. So when you improve performance focused on growth and critical thinking skills, it prevents issues. It helps staff recognize problems quicker. It gives them confidence to treat. It helps them in recognition of patients who are at higher risk for things such as falls and infection. And it helps implementing measures to decrease complications. Our prep projects helped us to focus on process measures through chart reviews and outcome measures, so we can measure decreased length of stay, decreased falls, decreased need for pain med and nausea med. And then our staff represent the organization. They are the face of the organization. They are the ones that the patients interact with. Patient safety is enhanced when staff have the skills and tools to safely care for patients and contribute to preventing never events. Patient safety issues need prompt attention. They always need to be your primary focus. Prep ideas for staff who need help with upcoming ideas are great ways to look at patient safety issues, but sometimes those issues need prompt attention. Sometimes then, if they need prompt attention, you need to go to your resource nurses and say, this is an ongoing issue that we found. Help us come up with a way to remedy this problem or situation. And in the end, hopefully, once you've done all these things, you will create confidence in the staff, which will create a positive patient experience and lead to positive patient outcomes. So the goals of education, hopefully, is that professional competence is updated and practice advances. Learning priorities that were identified through needs assessment have been addressed. And any change in practice as a result of the learning needs linked to the needs of the individual unit or department, hopefully those have been addressed, completed, and enhanced, and the staff come away with something. Continuing education, as I said, is a lifelong process. Education builds on current education experience levels to maintain or improve patient care, allows staff to stay current with knowledge, and allows them also to share that knowledge with their colleagues. The other thing too is being part of the magnet journey. Magnet hospitals always set the standards for practice. So in order to remain magnet ready, you need to stay competitive, and staff need to be kept up to date with current best practices that have been identified. So what works for us? Let the staff be creative, read the room, listen to the staff giving discharge instructions. When the patient asks questions, do the staff have the needed resources in their toolkit to be able to give a reliable answer, or do you see your staff struggling to provide an answer to that patient and family? Look at the patient and family members. Do they seem satisfied with the responses given to them by the nurse? Do different patients ask the same questions? If different patients are asking the staff the exact same questions, obviously this is something that can be identified as a potential opportunity, a potential need. And as I said, the PrEP program is a huge incentive for staff to complete educational projects and help you with your needs assessment. So using those observed needs to lead to a change in practice. So when we looked at opportunities for evidence-based practice projects and QI projects, we found that there's always needs that are available, always needs that pop up. So one of the things that we looked at was post-op nausea and vomiting. It's a huge dissatisfier. It's something that everyone struggles with. You try to you tried to attack it on, so many levels before the patient arrives, while the patient's in the operating room, after the patient is out of the OR in recovery room. But still, the staff were frustrated and thought, is there more that we can be doing? So of course, we went to the literature again. So we found that there was a lot of benefit in providing carbohydrate-rich fluids for our patients prior to coming in for surgery. So we thought, okay, here's another potential opportunity. So as I said, we were already doing a lot to combat post-op nausea and vomiting, but we thought, here's just another thing that we're gonna, throw at the patients as a means of prevention. So prior to the patients coming in for surgery, we had them drink 16 ounces of a carbohydrate-rich fluid. We look at something that the patients are actually going to want to drink, that they'll find tasteful, which would increase your chances of compliance. So we have them drink 16 ounces of a Sprite, a ginger ale, a 7-Up, a Gatorade, an apple juice, whatever they're comfortable with, to provide them that carbohydrate load prior to coming in. What have we found through all of this? We found that our nausea and vomiting has decreased. We found that the need to give out additional antiemetics has decreased. The other EBP project we did was we looked at pediatrics anxiety levels and how can we decrease those in our pediatric population. We found that using methods of distraction helped to alleviate anxiety levels. So we now provide our kids, if needed, with a handheld video game prior to going into the operating room. So they're given this in pre-op, they start playing these games, they're playing these games all the way into the OR. The next thing you know, they're on the table, still playing the game. Mask is applied, they're off to sleep, sometimes before they even know what hit them. Pediatric emergency situations. This was a big one, since 30% of our patient population is pediatric patients. Staff were uncomfortable when an emergency situation arose. So, okay, how can we tackle this? We decided to break it up into different things. So we're looking at emergence delirium. We're looking at different airway issues, laryngospasm, croup, exacerbation of asthmatic attacks, things like that. So we're looking at what are the staff's needs and how can we help them. One of our other EBP projects was looking at pain medication administration to our patients having bilateral myringotomy with tubes. These patients don't have IVs put in the operating room. So how can we come up with creative ways to control their pain? Some of our anesthetists squirt a little fentanyl, the aerosolized fentanyl squirted up the nose to help these kiddos with pain when they're waking up. Some of our anesthetists don't. So we needed to look at making sure that staff is recognizing if these children were having pain or not. The screaming that we were seeing, is it just an emergent situation when they're waking up, they're a little bit confused, they're hungry, they want their parents, or is it the need for pain medication? So also one other project was, how do we evaluate pediatric pain scores? Traditional methods that you use for adults does not work with children. Younger children require different means to evaluate pain levels as compared to older children who can actually participate in measuring their pain. Another thing that we looked at was BARF scores for our nauseated patients. We needed a definitive way to measure what that nausea score was, just like you measure, a pain score. Patients nauseated, you give them anti-nausea medicine. They say their nausea score is a little bit better. But, if their nausea score was a 9 and now it's a 7, yeah, it's a little bit better, but they're still really nauseated and probably still need some additional intervention. Other thing that we did was we look at ways to make traditional learning fun and engaging. Malignant hyperthermia is something that's very dry, very something that the staff do not look forward to every year. So let's think outside the box. So last year created a malignant hyperthermia escape room where the staff needed to work together in a team to diagnose the problem, come up with ways to treat, what resources are available to you, how are you going to identify, treat, care for this patient. It was a new learning approach that, again, still a very dry, boring topic, but the staff really responded to it and enjoyed it. So I guess what I want to leave you with is that there's multiple ways, I think, of providing the education and training that your staff needs. As I said before, I'm not an expert in this, but it's what seems to work for us. It's what seems to be the best for all of us concerned. So hopefully there was something a little bit that you could take away from this. And I guess now I don't have anything else to share with you. So I'm going to open up the floor for questions.
Okay, great presentation. Thank you so much, Judy, for sharing that with us. So that now concludes the slide presentation portion of our program. Now we would like to begin our question and answer period. So the first question is, can you please list the competency methods again? They heard survey, observation of unit work, but missed all the methods of competency assessment.
I'm sorry, can I list the methods of competency assessment? So survey, direct observation, demonstration, return demonstration. I think that was all I had.
Okay, all right, thank you. Thank you for the question. Also, here's another question. Do you use any type of patient outcome measures to help guide and assess the educational needs of staff? So what type of patient outcome measures? Sounds like you talked about the post-op nausea and vomiting. Is there any other type of outcome measures that you use?
So we always look at things such as like delay in treatment, how long does it take the staff to recognize that something's going on, whether it's something as simple as, an airway issue or something as complicated as an airway issue versus, your patient is coming in, they're expressing that they're having pain. How quickly can you administer that pain medication? As I said, we look at things like how long is the patient in the unit? Obviously, things such as pain and nausea are going to delay their ability to be discharged.
Okay, thank you. And you mentioned, I think, about the BARF score.
Yes.
What does BARF, is that a mnemonic for something, or what does BARF stand for?
No, it's not, but it's something we came across when we were looking through the literature for post-op nausea and vomiting, and it's like, well, how appropriate. So it's something that we actually have built into our electronic health record. What is the patient's BARF score? And it's a numeric score from 0 to 10, 0 being none, just like pain, 10 being active vomiting. And there is a picture to go with it, just like the Baker-Wong FACES scale. There's actually a BARF scale, so that if the patient can't readily give you a number, you can kind of look at them and sort of say, well, they're looking a little queasy, so they have to at least be this number or that number.
Okay, great. So then you would use that. You mentioned that you have a large pediatric population, so you would use that for your pediatric patients as well. Then the picture.
Yes.
Okay.
That's something that's nice that it can be used on your entire patient population.
Okay, great. Thank you. So when an issue is identified with job performance and it is determined not to be an educational means, such as noncompliance with hand washing, is that able to be addressed with a learning needs assessment?
Yeah, I mean, you can look at where does the knowledge gap occur, and address that areas and provide overall education, or it can be targeted education. So one of the things that we had as a need or a potential need was looking at our timeout process in the operating room. It's that final moment prior to the surgeon starting with the surgery, making sure that you have the correct consent, the history and physical, you have any lab work, EKGs, x-rays to have all the information prior to surgery, making sure that you have the correct patient, you're doing the correct surgery on the correct side, the correct site, things like that. So during the timeout process, all of these things are gone over. And the theory is that all work in the OR stops. All eyes are focused on the circulating nurse who's going over all of these. And what you're looking for is agreement from all staff members that, yes, I agree, this is the correct patient. Yes, I agree with the consent, we're doing the correct surgery on the correct site, et cetera, et cetera. Well, what we found out was some of our surgeons were kind of like, yeah, everything's good, but not really engaged. They were participating in the timeout, but they were not engaged in the timeout. So what we ended up doing was something very, very simple. We take the back table and we keep it away from the surgeon. If you don't provide them with the tools to start surgery, they can't start surgery. So therefore, they have to be engaged. They have to listen to what's going on and actively participate before they're allowed to start that surgery. It didn't take very, very long for us to, for lack of a better term, train our surgeons that this is the way we need you to do this. We need you to be present before we're going to allow you to start working. But it was a great idea that was thought of and implemented by our staff nurses, and it was a great way to identify a need to prevent a potentially catastrophic event from happening in the operating room. And it was something that was very easy to measure. So it was a win-win on all accounts.
Absolutely. And I will add that that actually was, you submitted that project and what you did for our 2024 IM Patient Safety. And that's the award that you mentioned that you won was for that submission, correct?
Yes.
Yep. So congratulations for that. And what a great way to implement sort of like a forcing function that you weren't allowing them to start surgery until you brought that back table over. So that's great. That's a great action planning on your part. Okay.
Yes, and one of the things that I've learned is, talk to your staff. They are the ones at the point of care. They are the ones who, for the most part, can come up with the most creative solutions to the problem. Sometimes they don't, outwardly recognize that there's a problem. Sometimes that's where your eyes come in handy. But then when a problem has been identified that you need to come up with a solution, go to those nurses. They're the ones that have the great ideas.
Yep. And you're absolutely right. And that is a sign of we talk about highly reliable organizations. That's your deference to your expertise. That's your frontline staff, because they're the ones that live it and, are in there doing it every day. So that is great advice. So our webinar will soon be ending, but we do have time for maybe one or two more questions before we end our program. So please feel free to put them in the chat box. Do you have any other questions? And it looks like maybe just one other question. How do you address gaps in skill? Do you use simulation or drills?
So when there's a gap in skill that's been identified, usually that's going to come, well, first of all, you need to know, is the gap in skill with all of your employees, some of your employees, or just one employee? So that will also help to direct you what you're going to do next. If it's a gap in skill for all employees, that's when, let's look at what curriculum can be developed. Let's look at what the needs are, things like that. But if it's an individual person that has a gap in skill, let's see, where they are, what they know, and how we can build upon their prior knowledge. I like to use the example, we had a nurse who came to work with us in the OR who used to work in the delivery room, and her learned skills were from doing C-sections. Well, there's a big difference between doing C-sections compared to doing a rotator cuff repair. So what we did was we looked at what does she already know, and how can we build upon and enhance what she already knows versus trying to start from scratch. So a lot of that came from her preceptors and mentors saying, you know, this is an identified need. What can we do? And then the other thing too is pairing those novice nurses with your more seasoned nurses, helping them, you know, train the trainer, or like, helping not train the trainer, but using staff to be educators at the point of care. That was another thing that we do and we rely upon very much.
Great, thank you. Thank you very much. I want to thank everyone for joining us today, and especially Judy for her presentation. If you experienced any issues accessing the evaluation and a certificate of continuing education, please feel free to direct any inquiries to Shelley Mikesell at shmikesell@pa.gov. This concludes our webinar.